right, guys, ready? I'm going to tell just a real quick story to introduce Dr. Mitiku, and then I'll let him introduce himself too. But I was working up on the CCU, and I had heard his name a few times, and I didn't quite, if you ask the nurses, you know, is that a resident, a fellow, an attending? Sometimes they don't quite understand. And we had a code, and he just happened to be, I think, on rounds. And he was looking at the screen, and he's ordering this and that, and an EKG and stuff. And someone had told me earlier that day that he was a cardiology fellow. So I'm like thinking, oh God, here we go with the cardiology fellows. You know, I'm going to have this big argument. And I hurry up and I sit down at the computer and I Google him real quick just to see. And it pops up that, you know, he did his medical school training at UCLA. He then went to Stanford and did an internal medicine residency, and he then went to Yale and did a cardiology and electrophysiology residency. So of course I popped in there, and at first, you know, he was kind of ordering stuff, and I'm like, and then I see all this, and I'm like, yes sir, Dr. Mitiku. So anyway, this is Dr. Mitiku. He's going to talk to us today about atrial fibrillation, and I'll let him take it from there.
Thanks for the kind introduction, Tim. So today I'm going to spend the first hour just giving you an overview about atrial fibrillation historically and what we know, how do we approach as electrophysiologists. And then the second hour, I'm going to spend more focus, what's more important in emergency room, managing atrial fibrillation.
Sir, I'm sorry, is there any way you can talk just a little louder?
Sure. Is this thing a microphone or what is this?
No, that's for us now.
Okay.
Will that be? No. I just remembered I didn't turn the microphone.
Oh, is that what it is?
You just have to speak louder.
Yeah, you just have to speak.
All right, okay. So,
Sorry. I'll work on getting the land here.
perfect. How does this thing work? I have no disclosure related to this talk. My hope is today to cover a little bit about an overview of atrial fibrillation and why it is important to talk about atrial fibrillation. Medical management of it, pulmonary vein isolation is what we do nowadays, trying to treat atrial fibrillation, and a little bit about atrial fibrillation in African American, since we serve a large population here in DMC. Why worry about atrial fibrillation? Atrial fibrillation is the most sustained arrhythmia that we normally see and we treat. And this seems to be growing exponentially. Roughly 10% of patients who are above age 80 have atrial fibrillation. And it's the most important cause of stroke, especially in that demographic. Significant morbidity and mortality, of course, from the symptoms, as well as from stroke and debilitating cardiovascular events. This is atrial fibrillation as it relates to the age. As you could tell, atrial fibrillation is a disease of elderly. But it doesn't mean that the younger people don't get atrial fibrillation. And the prevalence continues to grow exponentially. And currently there's roughly about between 2 to 3 million Americans who live with atrial fibrillation. And this number is projected to double in 2035. There is a significant health risk and cost associated with atrial fibrillation. There's a negative impact of quality of life, as you all know. And there's leading cause of stroke. If somebody is diagnosed with atrial fibrillation, the risk of having a stroke is 5 times without patient without atrial fibrillation. And this risk increases with time as the progression of the disease. And roughly we spend $12 billion in 2011 on treating atrial fibrillation alone. Currently probably close to $20 billion. And it's good to know how to define atrial fibrillation, especially in the emergency room. Traditionally atrial fibrillation is defined as a paroxysmal, somebody who goes into atrial fibrillation, not one time, the second time. Because if you have atrial fibrillation only for the first time, you call it lone atrial fibrillation. That's one time. But when you define a paroxysmal atrial fibrillation, you have to have at least a second episode that terminates spontaneously within 7 days. Persistent atrial fibrillation we define as an atrial fibrillation that lasts more than 7 days, or lasts less than 7 days, but requires cardioversion, whether that's pharmacological or electrical. And persistent or long-standing or permanent AFib is atrial fibrillation that you cannot restore sinus rhythm in a meaningful way with all the attempts that you do. But as an electrophysiologist, I look at atrial fibrillation not as a distinct categorized entity, but it's a spectrum of the same disease. And if you look at it, the way we define atrial fibrillation is continuum on the same line. When you are young and healthy and heart is normal, you have probably what's called paroxysmal atrial fibrillation. Diseased hearts usually have a chronic permanent atrial fibrillation, and persistent atrial fibrillation somewhere in between. And this definition is more physiologically makes sense because the mechanism of atrial fibrillations are different. Early on in atrial fibrillation is focal drivers that we know, usually located in the pulmonary veins. However, when you get a chronic or persistent atrial fibrillation, the whole atrium is actually the mechanism of atrial fibrillation is a multiple reentry circuit. It's not anymore isolated to pulmonary veins. It's everywhere. The whole atrium is a tribal. The whole atrium is in a sort of a reentry circuit. The goals of treatment for atrial fibrillations are listed here. The most important one is alleviating debilitating symptoms. Of course, those symptoms are due to rapid heart rates, loss of atrial kick, and we're trying to minimize symptoms, maximize quality of life. And if you are tachycardic for too long, or you have a ventricular dysfunction, we hope to preserve ventricular function by reducing the rate at which the atrium is going. Also reduce the risk of thromboembolism, and of course restoration and maintenance of sinus rhythm. We could spend the whole day talking about this slide alone. This is a schematic and the goals of atrial fibrillation, and we divide it into 3 different categories. They're all independent, but they're all interrelated. Most importantly, rate control, we could do pharmacologically, or we could do non-pharmacologically by ablating the AV node and pacing the patient. And if we decide to try to maintain or restore sinus rhythm, we could do pharmacologically with all these poisons, antiarrhythmics, or we could do it with traditionally by treating the risk factor that puts you into atrial fibrillation. I think this area is not emphasized well enough. Trying to prevent atrial fibrillation with ACE inhibitors, ARBs, a little bit so with calcium channel blocker, because atrial fibrillation is a chronic, progressive disease. It's an inflammatory disease. I'm not going into the pathophysiology of atrial fibrillation, but atrial fibrillation is, there's electrical remodeling, there's mechanical remodeling. When you have atrial fibrillation, the electrical remodeling can be restored, but the mechanical remodeling is actually permanent. When you have atrial fibrillation, there's a cascade of things that happens. Usually there's activation of MMPs, metalloproteases, that promotes fibrosis. So those fibroses actually sort of fill in the interstitial cells space, which propagates atrial fibrillation. Therefore, AFib begets AFib. The longer you're in atrial fibrillation, the more you're in an inflammatory phase. And the more you're in an inflammatory phase, the more MMPs are activated. The more MMPs are activated, the more you have essentially scar formation. And the more you have a scar, the less harmonious the cells will be together. Therefore, that would set up somebody to be permanently in AFib. And then pharmacologically and non-pharmacologically, we can cardio with somebody. We can do ablation. We can do surgical maze. And this kind of fell off favor, and it was a very favorable thing in late 1980s and early 1990s, implanting defibrillator in the atrium. And you could imagine trying to cardiovert the atrium alone. They used to put a coil in the atrium, but unfortunately the atrium is so thin, they used to perforate. So that came out of favor so quick. And the stroke prevention is another way we approach patients. Even you might want to control the rate or decide you want to maintain sinus rhythm, but this is a separate entity on its own. Whether you maintain sinus rhythm or rate control, anticoagulation is an independent entity. Because you maintain sinus rhythm, that doesn't mean they're not at risk of thromboembolism. And we do that by pharmacologically, warfarin, all antithrombotics nowadays, aspirin, and non-pharmacologically, which is ligating the atrial appendage. Roughly about 60,000 patients who get roughly about 60,000 patients with AFib get a stroke. And from those, the risk of a stroke, if you take all comers, is 3 to 5%. But high-risk patients really have a risk of 15% or more of atrial fibrillation. If you have a CHAT score of 3 or more, your chance of having a stroke is a 12 to 15% per year. This is not the lifetime risk, but this is a per year's risk. And this is without anticoagulation. And the risk, as I mentioned earlier, is 5 times greater than the risk without AFib. And in elderly patients who are above age 75, 50% of their strokes is actually due to or related to atrial fibrillation. That's a huge chunk of population that we deal with. Traditionally, we use a CHAT2 score to risk stratify who would need a Coumadin or anticoagulation. And probably everybody in this room knows this. How do we calculate CHAT2 score? And those are listed here. And the C stands for CHF, H for hypertension, A for age. Of course, this has been modified recently by CHAT2 VASC score, and D for diabetes, S for stroke. If you already have a stroke, you get actually 2 points. That's why the 2 comes there. So we define a low CHAT score, anybody less than 1 or 0, an intermediate 2 to 3, and a high risk group 4 or more. And this is a prevalence of stroke within that group per year. I'm not going to bore you with a lot of data to show you the benefit or the validation of anticoagulation, because it has been shown that the higher your risk factor is, the higher the risk of stroke is. And warfarin reduces essentially the risk of stroke. and the magnitude of the reduction is higher when you have a higher risk. This is a meta-analysis showing, as you could imagine, this is old studies, showing that warfarin is much, much better than without warfarin. I'm just going to have one slide for each of the new anticoagulants that we use. The biggest trend is Pradaxa. It's been released about almost 3 years now, and it's being studied. This study was powered to see non-inferiority, not superiority. But as you could tell, this thing is so weak. Warfarin has the risk of stroke is higher with warfarin than dabigatran. And this is dabigatran is 110 milligram and 150 milligram. So 150 milligram actually gives you better stroke protection than 110. And it wasn't powered to make the point of dabigatran is superior, but you could see from this data. So we could use the Pradaxa 150 milligram twice a day. But unfortunately, this drug is cleared by the kidney, and majority of the patients that we deal here in the DMC cannot be on this medication because of the renal function issues. Another anticoagulant that we readily use nowadays is called rivaroxaban, Xarelto. And again, this also shows clearly rivaroxaban is non-inferior to warfarin in the stroke reduction. And interestingly, rivaroxaban even have a less hemorrhagic stroke when there's a complication, less hemorrhagic stroke compared to warfarin. So therefore, rivaroxaban seemed to be winning because renal clearance is renally cleared, but it's not as heavily cleared as a Pradaxa. The other issue with the Pradaxa is the way it's formulated, the delivery mechanism has to be digested in the stomach. And unfortunately, a lot of patients have a lot of GERD symptoms. Up to 30–40% of patients have a severe GERD with intolerable to omeprazole actually. And those patients, we kind of trying to stay away from Pradaxa, sort of give us Xarelto more than Pradaxa. Rate control strategy, which you're all familiar with. This table kind of summarizes what measures we use to control the rates. And it's a very busy slide. Yeah, I will take you through it. Diltiazem, we use diltiazem like a water in ED. And unfortunately, the limiting factor of diltiazem is hypotension. And you cannot use a patient with heart failure because it's a negative inotropic agent. And of course, if you have a patient with a heart block, you can't use it either. And the verapamil, this is not medication that is favorable among cardiologists anymore because has a significant negative inotropic effect. The potent negative inotropic effect is the verapamil from all the calcium channel blockers. So therefore, a lot of people do not use verapamil unless you know that the person do not have cardiomyopathy or congestive heart failure and they are normal ventricular function. And beta blocker, again, similar issues. Propranolol can be used acutely. Digoxin. This is a drug that's very misunderstood because the use of it is the longest drug for all these groups. Digoxin has been in our use for more than probably a century. But this drug is not used appropriately. Unfortunately, digoxin as a solo medication for controlling arrhythmia or atrial fibrillation rates is not the way to do things. I'll show you why. And of course, amio is the drug we use. This is comparing all the drugs head on. And if you look at it, the best combination is ditch and atenolol. This is at rest. This is when you're exercising or exerting. That gives you the best rate control. But look at digoxin alone. Digoxin is a membrane stabilizer, and you'll be okay when you're at rest. But the minute you exert yourself or exercise, there's no vagolytic effect when you exercise because exercise is predominantly driven by sympathetic. You need a sympathetic block to control the AV nodal response. And then all other drugs are somewhere intermediate. This is the stuff. This is the rate control is a very tricky issue because we really don't know what's the optimal rate to control the ventricle. Is it 100 beats per minute? Okay. Am I that quiet?
Sing a little bit. It's American Idol.
Oh, I see. Is it on?
Not just.
On. Can you hear me? Yeah. So the overall rate control we're not sure what is the optimal rate to control. What is the rate control for a patient who's ambulatory? What is the rate control for a patient who are in ICU with septic shock and have a history of AFib? What is the rate control for a patient who have a normal ventricular function? What is the rate control for a patient who have a LV dysfunction and ambulatory? So to address this issue, there was a recent study that came out about a couple years ago. Traditionally, the way we use, the usual criteria that we use to rate control is rest is heart rate between 60 to 80 beats per minute, and moderate exercise 90 to 115 beats per minute. We used to put patients on a digoxin and beta blocker, put them on a treadmill, and that's how we used to titrate medication traditionally. So there's a study called RACE 2 trial that looked into a strict rate control, which is maintaining resting heart rate below 80 beats per minute. And exertional heart rate below 110 versus a linear heart rate control strategy, which is to maintain only resting heart rate below 100 beats per minute. This study enrolled 614 patients with permanent AFib treated with AV nodal blocking agent. So you want to use a patient who are permanent in AFib to sort of study, and relatively patients were younger and healthier, younger because AFib is a disease of elderly, and the primary endpoint is the death from any cardiovascular cause, hospitalization for heart failure, stroke, systemic embolization, as well as life-threatening arrhythmias. The results were very surprising for most. The linear rate control group has a lower mortality compared to strict rate control group. And if you think about it, initially it may be surprising, but not necessarily, because we're using again, I use the word toxins, we're using all these the drugs to push the heart not to beat at that rate. So therefore, there's a side effects of this medication, which is deleterious in long term for using it for rate control. And the conclusion that was drawn from this study was that strict targeting of heart rate seemed unnecessary for permanent AFib patients. Linear control, heart rate below 110, is not inferior to strict control, which is 80, we used to use. Linear control is more convenient and requires fewer outpatient visits. Imagine if somebody's rate is not controlled, we used to put them Holter, we send them home, and we titrate their beta blocker, they have to come back frequently to retitrate up and down. And these candidates, majority of them that was studied, were relatively healthy and their EF was 40% or more. So therefore, the caveat is, what is the long-term effect of tachycardia? And then if somebody is going to be tachycardic, you have to monitor them for LV function, because you could have a tachycardia-induced LV dysfunction. I'm going to change the gear here. We're going to rhythm control. Why normal sinus rhythm? Why do we want to put somebody in normal sinus rhythm, other than that's the way things intended to be?
That's what I want to know.
Yeah. And the most important is the proven benefits are, of course, the most important one is the relief of symptoms, improved hemodynamics. We know that hemodynamics improve. Of course, this has not been proven, but there are theoretical benefits. Decrease in the risk of thromboembolism, decrease in electrical atrial remodeling, which has been proven in animal model but not in humans, because it's harder to suction somebody's atrium, or the atrium is so thin, there's no imaging modality that we can use to tell the atrium has a fibrosis, because the atrium muscle mass is so thin, there's no way we can tell that difference. Even though there's a group in Utah currently doing MRI models where they're looking into how to image the scar burden in the atrium. And the primary disadvantage of trying to maintain somebody in sinus, again, the drug side effect, and then those drugs lead to life-threatening arrhythmias. And so far, there's no proven survival benefit with rhythm control, at least yet. This is the most recent guideline from American College of Cardiology, Rhythm Society, as well as AHA. This is a guideline they published in 2011 showing that if you want to maintain somebody in a sinus rhythm, this is the essential algorithm. Let me go first with the easy part of this. Somebody has no structural heart disease. That wasn't me.
Is it to scare people out here?
If it's, you could use any of these antiarrhythmics, dronedarone, flecainide, propafenone, sotalol. Essentially, any antiarrhythmics is available to you to use it if you have a structurally normal heart. And if any of these fail, then you could go to amiodarone or dofetilide, which are much more potent antiarrhythmics, or catheter ablation. I'll tell you, a majority of patients prefer catheter ablation because long-term effect of amio has a pulmonary, thyroid, liver, and all kinds of side effects that has to be monitored. So majority of patients prefer to go to catheter ablation. If you have a hypertension, and we normally assess if there's any substantial LV dysfunction. If there's no LVH, we go, essentially you use the same algorithm like here. If there is LVH, the only medication that's left is amiodarone because you cannot use any of these antiarrhythmics with a substantial LVH. What is LVH is defined as? People call concentric LVH with septum of 1.2, 1.3. That is LVH, but that's not necessarily. That's not going to stop you from doing it. These drugs, because when we, so I'm going to just try to speak louder. Sorry. When we say substantial LVH, we mean anything bigger than 1.5, 1.6. And the reason that is when you have a significantly thick muscle, the muscle, the pathophysiology of the LVH is in the middle of the septum or in the middle of the muscle. That area is not well perfused. So therefore, the matrix in that area usually is scarred because of less perfusion, because the muscle is so thick, they form a scar within this myocardium, and that set up the substrate for arrhythmia. So therefore, that's why when we say substantial LVH, we're talking about LVH of 1.5, 1.6 or bigger. Not necessarily everybody here that comes into DRH, they may have a LVH, concentric LVH of 1.3, 1.4. That should not limit somebody using these drugs. And then, of course, if you have a coronary disease, these antiarrhythmics are favored, the Federite, Tronedron, and Sotalol. And of course, if they fail any of those, you could offer amio or catheter ablation. As you can see, they all converge at the end to amio and catheter ablation. And if you have a significant heart failure, amiodarone and Federite are the only two medication drugs that's available for them. And then, of course, you might attempt a catheter ablation, even though the success rate of catheter ablation with somebody who has a structural heart disease is low. I'm just going to take a quick revisit AFFIRM trial. AFFIRM trial is a landmark trial, is essentially looking at rhythm and rate control strategy in terms of mortality. This is one trial that was misunderstood and that made essentially a significant delay in the treatment of atrial fibrillation in the community because the design was to check the overall mortality for AFib versus rate control. And the secondary endpoint was composite endpoint of the death and other cardiovascular outcomes. This is the main finding of AFFIRM trial. This is mortality. The rhythm control group had a higher mortality than rate control group. And these are the drugs that used, this is a proportion of the drugs that was used. So management of AFib with rhythm control strategy offers no survival advantage over the rate control strategy. And this study was designed in 1990s and completed in 2002. This was published in 2002. And it's a landmark trial that really made, essentially put a dent on atrial fibrillation treatment and made people to think carefully approaching using antiarrhythmic to treat patients with atrial fibrillation. But this trial did not compare sinus rhythm to atrial fibrillation in terms of mortality. They compared the toxic medication, whether to use those medications to treat, maintain sinus rhythm versus using rate control strategy with anticoagulation. So the results were as following. Sinus rhythm, there was 60%, only 60% in a rhythm control arm were in sinus. 35% in the rate control arm were also in sinus. All-cause mortality was much higher in the rhythm control strategy, less so in a rate control, and the stroke was much higher. And you can extrapolate why that is. Two reasons. One, in rhythm control, there's only 65% of using Coumadin. In rate control, because people assume if you're in a normal rhythm, you might not necessarily need anticoagulation. But in rate control, there were much higher prevalence of using Coumadin. So therefore, rate control is acceptable as a primary management option. But anticoagulation for all patients with one or more risk factors, as the risk factor is calculated from CHADS-2 score, regardless of whether you're in a sinus rhythm or not. AFFIRM trial did not compare sinus rhythm to AFib, but compared ineffective and toxic antiarrhythmic drugs to try to maintain sinus rhythm. An AFFIRM trial cannot be extrapolated to use as AFib is equal to sinus rhythm in terms of mortality. Again, AFFIRM trials did not include the patients which were younger patients or paroxysmal atrial fibrillation or patients with a heart failure, systolic reduced function, isolated diastolic dysfunction, or patients with disabling symptoms. AFFIRM trial enrolled all comers. They did not really look into the patient who might benefit from sinus rhythm. Of course, AFFIRM trial did not include pulmonary vein isolation, as well as using this antiarrhythmic with a cautious sleep. After a film trial, the FDA required all the patients who are going to be on antiarrhythmic. If you're going to start somebody on antiarrhythmic, they have to be admitted to the hospital, loaded in the hospital, check for the side effects of the medication, toxic effect of the medication, and whether that is a stress test, whether that is just watching their QT prior to discharge. And that led to more acceptable use of antiarrhythmics. And this is the efficacy of maintaining sinus rhythm in all those antiarrhythmics. They give you false impression that when you use antiarrhythmics trying to maintain sinus rhythm, majority of them fall below 50%. Amio is the only drug that gives you rhythm control that is acceptable. So are you going to expose patients to this antiarrhythmics and expose them to the side effects, and then increase the risk of having a torsade or other malignant arrhythmias? And as I mentioned earlier, so patients have to be looked into. They have to assess them for hypokalemia, hypomagnesemia, which are the substrate, and the substrate that makes patients to have long QT, and congenital long QT has to be looked into. And ventricular hypertrophy, as I mentioned earlier, those are susceptible patients who would have a torsade. If they have a bradycardia, and female gender, and of course drug metabolism, which we sort of understand now, but not fully. The pharmacogenetics still hasn't found out yet. I'm gonna so shift the gear again into the other ways that we can restore sinus rhythm, which has been revolutionized over the past 10 years. Pulmonary vein isolation. Current indication for somebody to have a pulmonary vein isolation is due to current indication for pulmonary vein isolation is as defined by Heart Rhythm Society as well as AHA, is a patient who has paroxysmal atrial fibrillation, who is very symptomatic and fails 1 or 2 class 1 or 3 antiarrhythmic drug without structural heart disease. It's acceptable to do a catheter ablation in a patient with symptomatic paroxysmal AFib with significant left atrial dilation, because I didn't go into details about where the atrial fibrillation comes from, but atrial fibrillation, as you probably could imagine, comes from left pulmonary veins. Majority of paroxysmal atrial fibrillations are due to left pulmonary veins. They are cholinergic atrial fibrillation, which are healthy, athletic, young patients who get atrial fibrillation. Those are from the right atrium, not necessarily not from the left atrium. Those are cholinergic. Those are roughly 5 to 10% of all the AFibs. So therefore, ideal candidate for ablations are symptomatic patients, because you can't make somebody feel better if they don't have a symptom to begin with. Younger patients, we like paroxysmal patients, the relatively normal size LA, less structural heart disease.
When you say symptomatic, do you include palpitations?
Yes. Palpitations are one of those symptoms that usually, some patients could ignore the palpitations. They learn to live with it. We don't really, unless that's really bothering them, we don't really define it as a symptoms. But they're exertional dyspnea, exercise incapacity, lack of exercise ability, heart failure, all those things are defined as the symptoms. Rationale for ablation is essentially we're trying to, to have atrial fibrillation, you have to have triggers and a susceptible substrate. And the goal of atrial fibrillation is to eliminate the triggers and also alter arrhythmogenic substrate, so that way the atrial fibrillation cannot be maintained. This is a cartoonish picture showing paroxysmal AFib, and this is a persistent or permanent AFib. Paroxysmal AFib, usually atrial fibrillation comes from the pulmonary veins of the left atrium. And this is a focal driver. Hence, that's why we isolate the pulmonary veins electrically. We do ablation around the veins. Or when you have a multiple reentry circuit, you get the whole atrium is a focal drivers. There's so many chaotic rhythm that we cannot define one single position to isolate. So therefore, to do atrial fibrillation ablation in this kind of patient, we have to suction the atrium in so many different compartments to control and debulk. Essentially, the way we look at it, we debulk the atrial fibrillation, because you need a critical mass to maintain atrial fibrillation. So you isolate the veins, and then you put a roof line, you put a floor line, you kind of box up the atrium, so it will not have a critical mass to sustain atrial fibrillation. How do we know that the atrial fibrillation comes from the pulmonary veins? Is essentially, this is a landmark study done by the French group. Asenguri and his group did a study on atrial fibrillation, and each dot represent where are the focal triggers of atrial fibrillation. As you can see, this is the right atrium, superior vena cava, inferior vena cava. This is the septum, and this is the left atrium. Imagine it's all clustered in the pulmonary veins. Those are the focal drivers of atrial fibrillation, and that's where the field of atrial fibrillation ablation originated.
Are those just abnormal cells that are firing?
Yeah, so there is a, when the pulmonary veins are not just stuck on the heart myocardium, so there is a venous structure interdigitating into myocardium structure. That creates anisotropy. There's a hemodynamic, whether that's a pulmonary hypertension or whether there's a sleep apnea, whether that is building up of left atrial pressure, stretches this fibers, where then you have a venous structure interdigitating with a myocardium. So those area where you have a two atherogenic tissue are the source of those. When you have a stretch, which is essentially what triggers atrial fibrillation, whether it's a left ventricular dysfunction, diastolic dysfunction, or pulmonary hypertension like a sleep apnea, are the source of atrial fibrillation. Majority of patients that you guys in ED are OSA patients.
All right, so when those cells start firing, is the fact that they're firing so much faster
Yeah, the sinus rhythm.
the SA rhythm is suppressed?
Suppressed, yes.
Okay, got it.
Yeah, exactly. Or it just overwhelms the SA.
Okay.
Yeah. So target of AFib ablation is elimination of the triggers, those are pulmonary veins, or modification of the substrate, essentially interruption of microintra circuits, compartmentalization of atrium, of the left atrium. Essentially, we create a roof line, we create a floor line, we create lines around different annuluses. So that way the electrical activation will not be continuum, and then essentially you reduce critical mass to maintain atrial fibrillation. And this is an example of atrial fibrillation. Here you got, on the surface, you got P wave and KRS. This is a catheter within the heart. This is a catheter in the left atrium, in one of the veins. And this is a catheter also in a corner sinus. So if you look at here, this is sinus V. This is a temporal relationship. This is the paper is running this way. And you get, this is V recorded, star field V. And you see that signal. The earliest signal in this relationship, in this temporal relationship, is in the vein, somewhere in the vein. That triggers atrial fibrillation. And of course, after that, the patient goes into AFib. And that's the source of atrial fibrillation. Those PACs or these focal drivers in the pulmonary veins are drivers of atrial fibrillation. Therefore, the cornerstone of pulmonary vein isolation is isolating the veins electrically by using radiofrequency energy, which is a heating energy to denature the tissue. And the way we do that is, we go to the veins, IVC, we do transeptal puncture, and we use the catheters to record. This is essentially sort of like a spiral catheter that has a 20, 30, however many poles that you have. It collects the information for you, gives you relative information within the vein. And then you have another catheter. This is the spiral catheter. This is the floor picture. And there's another catheter that you transeptal and doing essentially point welding. You go around the circle and then do the ablation. And if you do successfully, look at the surface here. PQRS, sinus rhythm, right? And this is sitting in the vein. And the vein is in AFib. You've successfully isolated the vein from the rest of the atrium. So therefore, the patient is in sinus rhythm, even though the veins are in atrial fibrillation. And that's a successful ablation.
So is the ablation inside the vein or in the atrium itself?
Actually, in the atrium itself. So I'm glad you asked that question. At the beginning of the field of AFib ablation, we used to do inside the vein, at the os. By doing that, we actually created so much trouble for patients because pulmonary vein stenosis was a huge setback for AFib ablation. So we learned from those mistakes. Now we ablate actually just around the os of atrial fibrillation, and I will show you an example of that. So we normally do not ablate in the vein, so we ablate around the os of the veins. And there are many techniques to ablate. You could ablate it like this, you could ablate it like that, you could ablate it like that. So you could section the whole right side together, left side together, and then that's what I was talking about, roof line. So what is the success rate of catheter ablation? It's roughly about 60 to 80% for paroxysmal atrial fibrillation, and often requires second procedure because when you do ablation, there's edema formed around the veins, and those edemas occasionally gives you the impression that you're actually isolated, and you might not be able to tell the difference whether you're fully isolated versus still partial connection between the atrium and the veins. Usually the most common thing that we see is atrial tachycardia or atrial flutters, as you could imagine, because now we create a scar in the left atrium, and the scar is a nidus for atrial tachycardia or atrial flutter. Now you have all these lines around, and as you know, the flutter that we get, a typical flutter that we get, is due to cave tricuspid isthmus area because of slow conduction to that. And if you have a scar, there's a structure for the electrical circuit to go around. So therefore, you're making this patient susceptible now for atrial tachycardia or atrial flutter. That's the most common arrhythmia that you see after AFib ablation.
So what percentage are free of both of AFib and other atrial tachycardias?
With the first procedure, roughly the numbers that quoted most literature are roughly around 70%. The recurrence of that is 3 years out, for 3 years out. But majority of the patients that we do nowadays, actually, we partly ablated most of our systems, so we're creeping into the persistent AFibs. So those numbers are dropping lower and lower. Roughly about 60% of patients are free of atrial fibrillation or atrial tachycardia or flutter. That is without any antiarrhythmics. Of course, you could get your numbers better by ablating them and putting them on antiarrhythmics. So this is a sort of a recent publication. No, this is all publication from an Italian group. Paponi is an Italian group showing the AFib-free after ablation for paroxysmal AFib. But this is a study patients. So in real world, this is not how pretty they look. This is a Chicago group that Dave Wilbur and his group that published this AFib. So this is a success rate that they published. This is a years, up to 7 years. Their experience is 72% off antiarrhythmics.
Does that include all patients and the Mitiku who had atria that were greater than 5?
No, this is for patients who have in the study who were normal atrial size or border. So atrial is, atrial size is defined, normal is defined anything less than 4, but it has to be indexed for body size. So if you just use a cutoff for atrial size using 4, then it would increase the chance of having so many patients excluded from the study. So they index it for the body surface, and those are actually presumed to be normal size atrium. This again, paroxysmal AFib and persistent AFib, even though this is a much earlier study, shows the success rate is much less in a persistent or permanent AFib than is paroxysmal AFib. And AFib ablation is essentially putting all your risk up front by the ablation. It has a significant complication risk. The complication risk is 1% of thromboembolism, because imagine you have 2-3 catheters in the left atrium, you are anticoagulating them, but every time that you are ablating, actually you're forming essentially potential for thrombogenesis. And cardiac tamponade, because you could perforate. Pulmonary venous stenosis used to be an issue before, less so now. Esophageal injury, because esophagus is just behind the posterior wall of the left atrium. And phrenic nerve injury, because if you ablate lateral wall of the left atrium, if you're creating a lateral wall line, you could injure the phrenic nerve. Embolus, because you have all these catheters sitting in the left atrium. Of course, they're all irrigated. And of course, acute coronary syndrome or post-procedural arrhythmias. In conclusion, sinus rhythm AFib are not equivalent in terms of mortality, and we know that from observational studies. But when we trying to restore sinus rhythm, if we use class 3 or class 1A antiarrhythmics, we're going to be aware of the risk of postoperative dupont. And that can be reduced by screening EKG, by knowing their kidney function, as well as their magnesium and potassium. Rate control strategy as a primary therapy for AFib is reasonably acceptable strategy. Anticoagulation for all patients with one or more risk factor, whether they're in sinus or not, whether we ablate them into sinus or not. The anticoagulation decision should not be based on their sinus or atrial fibrillation. It should be based on the risk factor.
So what about when you ablate somebody, you make decisions about anticoagulation?
So if, let's say we're ablating a patient who has a CHOP score of 1, and this is paroxysmal AFib, peri-procedurally we have to anticoagulate them because we create a lot of inflammatory response. And once we anticoagulate them, and then the risk of the chronic use of anticoagulation, the ablation procedure has no bearing on whether we ablate them or not. It's based on the CHOP score. So therefore, if CHOP score is 1, and then after ablation, after wait-out period, we could resume back aspirin. Or if the CHOP score is 3, I would indefinitely continue anticoagulation, whether they're in sinus or not.
Why? If they stay in sinus rhythm, why?
Unfortunately, the atrial fibrillation is currently the way we understand it is an inflammatory disease. So clot formation, not necessarily solely based on flow of blood through the appendage, is also there's inflammatory milieu that makes patients to be high risk of clotting. So therefore, we base anticoagulation based on the CHOP score, not necessarily atrial fibrillation. Of course, we also understand that sinus rhythm puts you at the lower risk of forming a clot, but we're not there yet to say sinus rhythm is gives you a less of risk.
Because I thought maybe you'd say, hey, how do you know the patient's not going into paroxysmal atrial fibrillation every once in a while? You don't have a Holter monitor on them.
Yeah.
365 days a year.
That's exactly. You might have a little isolated atrial fibrillation that may happen. That it may be asymptomatic now because you suction the atrium differently. So there are a lot of reasons why people don't want to. At least the society now understands that maintaining sinus rhythm will reduce your risk of thromboembolism, but does not eliminate. Therefore, nobody's going to make the decision at this point, at least from the field where the field stands, to withdraw back the anticoagulation.
It would seem like from a cost-benefit perspective that if you can't discontinue anticoagulation, then a lot of the opportunity for cost savings with ablation going away, it's going to probably not be that favorable from a cost-benefit perspective.
From cost-benefit perspective, but the symptomatic benefit is huge. Reduction of frequent doctor visits, ER visits, all those things. Those are the perceived benefits. Cost effectiveness.
Has anyone ever done a cost-benefit analysis?
Yeah, they have done a cost-benefit analysis. There's also actually interesting that has been done. Cost analysis has been done and shown that patients who have actually atrial fibrillation ablation have a less frequent symptoms, less frequent ER presentation, less frequent hospitalization from AFib, and therefore it's reasonable to do AFib ablation as a primary approach, even without trying any antiarrhythmics. And to even go one step farther, there's an article that came in JAMA last year showing that they took patients, all the patients that had atrial fibrillation ablation and the traditional way of managing atrial fibrillation, and they compared the two when they did a mini-mental exam and an IQ test. And they found that patients who have atrial fibrillation ablation has a less evidence of dementia, less evidence of memory loss. So there's a chronic thromboembolism. What's that? Sure. So they have all those benefits. And essentially that was a huge news last year when that came out, because there must be something that we're doing to the atrium that's benefiting, reducing the risk of, because when you're in atrial fibrillation, even though you don't get this big bang stroke with anticoagulation, you have this microembolize that we get. So those are the risks involved with chronic AFib.
So can I ask you a question about ablation? So you talked about the abnormality of the pulmonary vein. In an older individual who has a higher CHAD score, I'm assuming that they have a re-entry phenomenon?
Yes.
And so they wouldn't be a candidate for ablation?
They won't be the ideal candidate for ablation.
So in that individual, how do you decide whether or not you're going to try ablation?
So the majority of those patients are driven by essentially symptoms. So let's say somebody is age 75, they have a structurally, their heart is, let's say EF is 45, 50%, and they have atrium is a 5.5 centimeter size. And and they're very symptomatic. They come to the hospital, recurrent admission for, every time they go in AFib, they have diastolic dysfunction, global systolic dysfunction, they get admitted. And finally, you get called in to evaluate this patient. Is there utility trying to restore the rhythm? So normally, the traditional way we approach this patient is we anticoagulate them, and then given the atrium size is big, we have to put them on antiarrhythmics, trying to restore sinus rhythm, and see how they do. So you put them on a strong antiarrhythmic, depends on their renal function, depends on their LV dysfunction from the algorithm I showed. And then once you put them on those, restore the sinus rhythm and see how much you can maintain sinus rhythm with these antiarrhythmics. If you could successfully maintain sinus rhythm with these antiarrhythmics and patients significantly improve in their symptoms, now, and then they still have a breakthrough atrial fibrillation ablation will be adjunct additive benefit on top of antiarrhythmics. So therefore, we send those patients to reduce the substrate for atrial fibrillation. So therefore, we do ablation, understanding the risk of recurrence is very high, but we're not intending to take them off antiarrhythmic. It's just to increase their chance of maintaining sinus rhythm. So therefore, we do ablation of those kind of patients.
So what's the percentage of success in those people?
Roughly 50. Without antiarrhythmics. But if you put antiarrhythmics, the success rate could go up to 60, 70, it depends on the substrate. So it's a combination of two things that we do, trying to increase their chance of feeling better.
So once again, is it decreasing the mass of abnormal cells that are firing?
So essentially, it's isolating the mass of the cells that connected to the atrium that's firing.
Okay.
Yeah. Electrically isolate them, because that means when we do pulmonary vein isolation, we burn around the os of the pulmonary vein, and the way we can tell that there's no connection between the two is because we have let me go back and show you this catheter here. This is a recording catheter. If we're burning around here, and when we completely isolate, there won't be electrical signal coming from here to end. So we could tell that because we put this recording catheter deep in the vein to tell us whether that is communicating with the rest of the atrium. And if you're doing this while they're in atrial fibrillation, and if you do successfully all the 4 veins, the patient actually converts into sinus right there in your hand. So that's how you can tell that you isolated. And of course, we do tests, we paste in there, measured here, we paste. I mean, there's many maneuvers that we do to tell that we isolate the veins. But for persistent atrial fibrillation, we don't only stop there, because now we know the substrate is not only veins, because from persistent atrial fibrillation, you have this scar tissue forming everywhere in the atrium. the whole atrium is capable of maintaining atrial fibrillation. So we suction the atrium by putting a line on the roof, by putting a line around the mitral annulus here, connected to the coronary sinus, take it up to the appendage. So suction the atrium in a way that it would not have a critical mass to maintain atrial fibrillation. There is a critical mass. We're not sure how much it is, but by suctioning the atrium, we reduce the chance of them having atrial fibrillation. Just what they used to do, the surgeons used to do by doing the maze procedure. Essentially, they used to suction the posterior wall of the atrium by putting scalpels around, and that would reduce the critical mass for atrial fibrillation. And the main reason to ablate patient is to improve the symptoms. Again, without symptoms, we don't usually do atrial fibrillation ablation. Ablation can be, if somebody young enough to present and they have a very symptomatic atrial fibrillation, ablation can be done as a primary approach for treatment of atrial fibrillation. They don't have to exhaust all the antiarrhythmics before they get an atrial fibrillation ablation because because the young and antiarrhythmic affect somebody, let's say age 30 till they die, is a huge burden taking those antiarrhythmics. They might just get ablation and get rid of the atrial fibrillation because the success rate on a younger patient is significantly higher than somebody who's older. I'll skip this part and go to my next. Any questions for this?